Greetings and salutations, everybody. It's Dr. Ryan here. I'm a board-certified specialist physician. I thank you so much for joining me in the third in the series called OSCE. So as we know, OSCE stands for Objective Structured Clinical Exam. This is with a view to preparing us. If you're a student, if you're a registrar, if you're a resident in internal medicine, this is for you. If you haven't yet subscribed, I strongly encourage you to do so. Today we are tackling proteinuria. Okay, guys. Describe what you see and provide a differential diagnosis of diseases that cause the below. I'm so sorry that it's not the best quality image, but this in fact shows proteinuria, and this is lovely foamy urine which shows us proteinuria, right? So that's a urine dipstick test on the left, and the second was foamy urine, probably due to high protein leakage. How do we stratify causes of proteinuria? Well, broad stratification principle number one. Departure point number one. Is it renal disease or is it non-renal disease? Nice place to start. If it's renal disease, you're thinking about glomerulonephritis, right? And it's nice to do a urine PCR, protein creatinine ratio. And then if the ratio is above 0.35, which is 3.5 grams per 24 hours, that equates to nephrotic syndrome. And we spoke about nephrotic syndrome in times past, right? Diabetes mellitus can cause proteinuria, as can amyloidosis, systemic lupus erythematosus, drugs, right, like gold and penicillamine, both of which are probably fallen out of favor in recent years. And we have other disease-modifying anti-rheumatic drugs and other chelators to use, right? Malignancy, like myeloma, and infection. I want to draw attention to the fact that hypertension in and of itself should not cause proteinuria, right? Non-renal disease, things like fever, severe exertion, severe hypertension, burns, heart failure, and orthostatic proteinuria, which means that proteinuria occurs when the patient's upright but not lying down, and the first morning sample will demonstrate that, right? And causes of transient proteinuria, right, which is not there all the time, is cold exposure, vigorous exercise, febrile illness, abdominal surgery, and heart failure. Okay, looking at a quick approach to glomerular disease is taken from my framework series. I encourage you to go and have a look at the full video on glomerular disease earlier on in my channel. So essentially, glomerular disease divides into nephrotic syndrome and nephritic syndrome. So if you have proteinuria above 3.5 grams per 24 hours, that's nephrotic syndrome, complicated by hypoalbuminemia and edema, right, together with hypocoagulability, dyslipidemia or hyperlipidemia, and immunoparesis with infection, right? And in nephrotic syndrome, we further stratify into whether it's a primary etiology, usually in the setting of focal segmental glomerular sclerosis. Watch out for this, especially amongst obese patients. And it's also a collapsing variant in HIV, right? But that wouldn't be primary, that'll be secondary to HIV, right? Then we got the membranous glomerulonephritis, which is common in adults, and minimal change, more common in kiddies. Minimal change variety is steroid responsive. Then we got nephrotic syndrome, which is secondary to other etiologies. Most commonly, diabetes, and more diabetes. You got a diabetic patient who comes in with proteinuria and with elevated lipids. You're thinking he probably has nephrotic syndrome. Quantify that proteinuria and start him on his statins and on his enalapril, which is ACE inhibitor, and on his non-dihydropyridine calcium channel blockade. Right, this is with a view to curbing the proteinuria and get glycemic control. Right, preeclampsia can cause it. Medications, like we spoke about, infection, malignancy, lupus, and amyloidosis are other secondary causes for nephrotic syndrome. Nephritic syndrome is a different kettle of fish. You got hemoproteinuria together with hypertension and azotemia, and that is not the topic for this particular video. This is taken from knowledge.com. It's a lovely little acronym to remember the causes of nephrotic syndrome, right? So the acronym is FSAM-MD. FSAM-MD. F is focal segmental glomerulosclerosis. S is for systemic lupus erythematosus, the wolf. Ow! A is for amyloidosis, which also causes bilateral renal enlargement. Then M is membranous glomerulonephritis, common among adults. M is minimal change, common among kids, and steroid responsive and diabetic nephropathy. Right? FSAM-MD. Nice one. Another way to represent this is with the acronym DAVID. There's a nice statue of King David right here. Nice. D is for diabetes mellitus, A is for amyloidosis, V for vasculitis, I for infection, and D for drugs. Okay, my friends. The Lord Jesus told us in the book of Matthew chapter 24 verses 38 through 39, for in the days before the flood, people were eating and drinking, marrying and being given in marriage up to the day Noah entered the ark, and they knew nothing about what would happen until the day of the flood came and took them all away. We must not be ignorant of the fact that we are living in the last days. When we look around us and see the happenings in the world, the natural disasters, the struggle for power, nation rising against nation, and we also see the characteristic of people, boastful, proud, abusive, disobedient, unloving, without grace. We realize that we're living in the last days. And just like how it was in the days just before the floods came, people were making merry and were having no relationship with God, no regard for holiness, and the Lord took them away. So Jesus is coming back, and I pray that we will be in readiness for him. Let us use wisdom, and like Moses said, let us number our days that we may present a heart of wisdom. Thank you so much, guys. I'll see you soon with another handy video in this series. God bless you. These are my references.